Okay, well, welcome everybody to this webinar that's being put on by Navita Kashal. And again, this is a refresher course, I guess you could call it, covering the ACNS EEG terminology. And I am just going to hand it off to Navita and she can begin.
Hey everyone, good evening, good afternoon. It's 4 p.m. on Eastern side, so good evening to all. And we're going to talk about not everything of EEG ACNS terminology, just cream of the terms that we are using on our everyday work life. Tom Visarma gave this terminology talk over a year ago. And he kind of tried to cover almost everything, but here I have only, I would say, a few terms that will make our EEG documentation and understanding of those patterns a little bit better. Okay, so EEG terminology revisited. I am using the ACNS guidelines, ACNS EEG patterns, just to stay consistent. I'm not using real-time EEGs or the videos of EEGs that we have been monitoring or we have monitored in the past. All the EEG samples that I have is from the ACNS terminology EEG patterns. The outline of this webinar is we are going to revise terms on background, rhythmic and periodic discharges, electrographic and electroclinical seizures. I'm going to talk about birds and a little bit about interictal continuum pattern. So when you describe background of whether it is an ICU EEG or it is an EMU patient EEG, we talk about symmetry, right? The voltage and the frequency, whether it is asymmetric or symmetric, if there is a mild or marked asymmetry. What is a predominant background? Now, mind it, this is a little different. It's a lot different than describing the PDR of a patient. Whether the background is alpha, beta, delta, or theta, and then you come to if the PDR is present or absent. Delta and theta are not PDR. We are talking alpha range, 8 to 13 hertz. Whether it is present, it is absent, or it is not clear at the time you're monitoring patients, because let's say a patient is sleeping or patient is intubated, comatose, we do have absolutely no idea of the PDR of the patient. If you are counting the waves, please make sure you avoid the alpha squeak. What is the continuity of the pattern? Is the pattern continuous, near continuous? Either it is burst suppression or attenuation. We will talk about that as we go along. Now the reactivity. I am not going to involve the reactivity patterns in this presentation. So when you talk reactivity, there is change in frequency and or voltage. And in some instances, morphology of the background, of the pattern that we are being seeing. So you describe it if the pattern is reactive, non-reactive, it is unclear, or maybe it is unknown. The patient is in the same position from last 4 hours throughout your shift, and you just don't know if the pattern was ever reactive or not. Now, pattern can be stimulus-induced. So you can have stimulus-induced discharges, rhythmic activity, spike wave discharges, maybe stimulus-induced interictal continuum appears, stimulus-induced birds appear. So EMG and eye blinks is not part of the reactivity. So you are describing the EEG pattern with any sort of reactivity with the patient. What about continuity? So there are 4 ways to describe the continuity of the pattern. Either the pattern is continuous or near continuous. I'm going to show you the EEG images, the EEG pictures of this. The pattern is discontinuous, or it is burst suppression or burst attenuation. It depends on what percentage of the record is attenuated or suppressed. So let's look at those images. I'm going to go reverse. When I show the images, we will start with burst attenuation or burst suppression pattern. So more than 50% of the record is attenuated, of the epoch is attenuated. Suppression is a complete suppression of interburst interval, and however, attenuation, you will see close to 10 microvolts or less of activity in between the bursts. A discontinuous pattern is between 10 to 49% of attenuation or suppression. It's a very thin line between pattern being discontinuous or burst suppression, because from 50%, your burst suppression pattern starts, but less than 50%, less than 49% is a discontinuous pattern. So take an epoch, 15 seconds of epoch, look at least 5 to 10 of those epochs and decide if the pattern is discontinuous or you are going to mark it as burst suppression or burst attenuation pattern. So 10 to 49% of suppression in an epoch for a couple of epochs is going to define the pattern as discontinuous. Near continuous pattern is when you see 1 to 9% of the record. Only 1 to 9% of the record is attenuated or suppressed. And the suppression is lasting for more than 1 second. And then, of course, we have continuous where there is absolutely no break between the patterns. The 2021 terminology has two main terms. Now you use these two terms along with each other. You're using term 1 and term 2 in any combination. So we have generalized, lateralized, bilateral, independent, multifocal. So this is based on the localization where the pattern is present. Then we have based on the pattern. What kind of a pattern are we seeing? Are those periodic discharges? Is this a rhythmic delta activity? Or those are spike wave or polyspike wave? So you combine main term 1 and main term 2 to define your rhythmic and periodic discharges. So when are you describing, you will use the term generalized. When the pattern is generalized, you're going to specify where exactly it's happening. Earlier, we used to use the term FERDA, TERDA, OERDA. We are not using that. So you specify the location, you have a generalized pattern, which is either frontally or temporally predominant or maybe occipital predominant. Now, if that pattern is occurring on one side, it is unilateral. It's a lateralized pattern. Then there can be bilateral asymmetric. Most of the voltage that you are seeing only on the one side, only one hemisphere. Then we have unilateral independent. So all the 4 lobes are acting on their own, producing independent pattern only on one side of the brain, only in one hemisphere. So that pattern will be defined as unilateral independent. So you're going to specify if it is symmetric, asymmetric, and then you're going to tell the location. If it is multifocal, multifocal is a pattern we not just only see in neonates and peds population, we are seeing it in patients with the deep brain area stroke, with the injury to the brain and multiple other reasons. We are seeing multifocal discharges, multifocal patterns, even in ICU adult population. So you are going to specify if the pattern is symmetric, asymmetric, and where are those multifocal discharges happening. So multifocal can be one hemisphere, can be both the hemispheres. So here is an example. So here we are using both the terms, term 1, main term 1 and main term 2, and describing this pattern as bilateral, synchronous, and symmetric periodic discharges. And they are frontally predominant. So the PDs is a main term 2, generalized is main term 1. So we are combining both the main term 1 as well as main term 2 to describe this pattern. Here is an example. So 1 Hertz frontally predominant GPDs. Here is a lateralized pattern. So periodic discharges are present only on the left side. So these are LPDs, lateralized periodic discharges. So during this presentation, there will be some questions. The questions will look like this. This is not the question that I'm asking you. So how would you characterize this pattern? So here is a explanation given in the ACNS training module. So here they're saying the morphology is spike and wave, but these are not just spike and wave complexes. These patterns are appearing periodically. So these are lateralized periodic discharges of spike and wave morphology. And when it comes to defining their frequency, we have 6 hertz continuous lateralized periodic discharges of spike and wave morphology. So if you're defining this pattern, that's how you're going to quantify it. You are going to say which part it is appearing, if it is generalized or lateralized, and what is the morphology of these discharges. All right, here is a question. Jeff, you want to take over?
Yeah, so you can see the pattern. Here's the question. There are the 4 choices. I'm going to pause the slide and we'll hopefully launch the poll, and then you can put in your answer. So I'm going to give you a moment just to look at this and come up with your answer, and then we'll blank out the slide and the poll will come up and you should be able to address it. So answers are being added, and we'll give it another 30 seconds here, or another 20 seconds in order to address this. Okay, I'm going to end the poll now.
All right, 70% of you said these are left LPDs with mild spread to the right. So this is the way we used to describe the EEGs before the ACNS terminology came out. That's how we were describing. So it is not wrong. It's not wrong. And bilateral asymmetric LPDs, that's what is described in the ACNS guidelines in the terms.
Oh, go ahead.
No, that's fine. Yes. So here it is. So lateralized periodic discharges, bilateral asymmetric. So if you are saying these are left-sided LPDs with a spread to the right, that is also correct. So answer can be B and D. So by giving answer B, you're not wrong. It's just that you are using the newer terminology. And 70%, even including me too, I still describe this pattern as mild spread to the other side. All right, good job there. Here are bilateral independent discharges. So you are seeing the discharges, periodic discharges on the left as well as right, and they do not match. So 2 sides of the brain, 2 hemispheres have a brain of their own. So basically these are bipeds. So we are not using the letter E anymore, right? So bipeds, the lateralized pattern occur on each hemisphere, and it is asynchronous. Not just it is asynchronous, it is occurring at different frequencies. So here is another question. How would you characterize this pattern? What you're looking at? Is it GPDs? Are these sporadic sharps? Are these bilateral independent GPDs, or are they fluctuating discharges? Jeff, take over, please.
Give me one moment and I'll be ready to launch this one too. All right, so you should see that come up on the screen now.
Okay.
Give you 5 more seconds. I will end the poll.
All right. For those 11% who said sporadic sharps, always keep in mind, sporadic sharps are not rhythmic. Here we are seeing the discharges as rhythmic. Okay, so these are bilateral independent generalized periodic discharges. Whatever fluctuation is happening is not significant enough that we either categorize them as fluctuating or sporadic. So these are bilateral independent. But if we go what we have learned back in when we were working in the hospital and when we were in school, so we are going to describe them as GPDs. And they are significant at the left and the right centrals. But the new terms is talking more about bilateral independent generalized periodic discharges. They are present throughout the brain, even if they are of maximum voltage at the centrals, but they are independent of each other. So both the centrals are behaving on their own. So bilateral independent generalized periodic discharges. And if you add of central predominantly at centrals, that is not wrong. Okay, the correct answer was C. So here are, if you can see the orange and the green arrows, they are at different time points. So bilateral independent periodic discharges or BIPDs. All right, the next main term is unilateral independent. So you see the discharges only on one hemisphere, one side of the brain. But they are not happening at the same time at all the locations. So maybe the frontals are different from the centrals or the parietals or the occipitals. So periodic discharges on the anterior and the periodic discharges on the posterior do not match. So these are asynchronous and occurring at different frequencies. Unilateral independent lateralized periodic discharges. All righty. We have this image here. There is no question here. If you look at this image here, the green and the orange arrows, they are on the left side, and the green on the central and then on the left. Now these discharges are happening at different frequencies and they are totally asynchronous. So these are unilateral periodic discharges. Multifocal. So these multifocal discharges, these are the generalized multifocal periodic discharges or MFPDs. They have 3 independent foci here. So you see their left anterior, left posterior, and then there are discharges on the right side, which do not match anyway in frequency and at the time point where they are occurring. So here is an example of multifocal periodic discharges. There are 3 independent focal points of these discharges. One is in the left, which is enclosed in this rectangle. And then we have an arrow, which is defining it at F4, C4. And then we have stars, which are defining the discharges at C4, P4, P4, O2. So at 3 different focal points, we have multifocal periodic discharges, both on the left as well as on the right side. Another confusing term when we are describing our EEGs, when we're describing our pattern, is difference between burst and a discharge. Now a burst, a discharge is a shorter thing. It happens and it goes away. So anything that is less than half a second is a discharge. But do the discharges happen longer than half a second? They may. If you are not sure, if you are seeing that a pattern which is appearing for more than half a second, you start counting their phases. How many phases does it have? If a pattern is longer than half a second but has only 3 phases, it is going to categorize as a discharge. But a burst is always longer than half a second. It has more than 4 phases. So you count the phase only when you see that, okay, a given pattern is more than half a second. Am I saying it is a burst or am I saying it is a discharge? So a longer than half a second but it is still within 1 second window, you count the phases. 4 phases means it is still, we are still categorizing it as a discharge. A burst lasts anywhere from half a second to 30 seconds. So after 30 seconds, you can define the pattern as being discontinuous. So a burst is usually more than half a second, and it goes as long as up to 30 seconds. And bursts usually have at least 4 or more phases. Another confusing term that we have difficulty describing when we see that these patterns, these discharges, they are jumping from one point to another. They are changing in frequency. They're changing in frequency, they are changing in morphology, and maybe their voltage is becoming different. So then we put them under a category of shifting predominance. That predominance, like I said, it could be frequency, it could be morphology, it could be their voltage. So here is an example of generalized periodic discharges with shifting asymmetry. That asymmetry we have is voltage here. So the predominant thing here is happening is change in voltage, but the GPDs, they are consistent, they are continuous, and they are a little less than closer to 1 hertz. So we have GPDs of shifting voltage, or they have shifting asymmetry. If you see here up top, we have left is lower, but the right is higher. But in the very first epoch, left has higher voltage and right has a lower voltage. So you can always describe your GPDs with their fluctuating predominance of maybe they're jumping from one channel to another channel, or maybe they are changing in voltage and frequency also. Another is sporadic. The sporadic discharges are never rhythmic. So they are non-rhythmic, non-periodic. They are still epileptiform discharges though. They could be interictal pattern also. Now, when you see sporadic discharges, you are going to describe them based on their prevalence. How often are they appearing? If they are appearing for more than once in 10 seconds, so your epoch is usually 10 to 15 seconds. If they are appearing for more than once in 10 seconds, you call them abundant. Frequent is they just once or twice, maybe in 1 minute. Occasional, you see them once in a while in an hour or in a minute. So those are occasional. So that's quite a wide range of window that 2021 has adopted. And the rare sporadic discharges are less than 1 in an hour. So in your 4-hour shift, you see them maybe just once. So sporadic discharges, non-rhythmic, non-periodic, epileptiform kind of a morphology. Along with those main terms that we talked in the beginning, we have major modifiers. These modifiers are used to describe the description of the pattern that we just talked about, GPDs, LPDs, bilateral independent, RDA. To refine the description of the pattern, we are basically adding more to it. We are quantifying them. So prevalence, duration, and frequency. These are your time-related scale. That's how you quantify your pattern. Just saying the patient is having GPDs is not enough. We want to know, are those GPDs happening continuously? Are they happening? Is there a discontinuity in between them? Are they happening sporadically? Are they periodic? Are they happening once in an hour, right? So you use a time scale of prevalence, duration, and frequency. We're going to talk about that. And then the other 2 major modifiers that I have included in this talk is plus modifiers and the fluctuating discharges. We're not going to talk other ones here. So here it is. When you talk frequency of a given discharge, given pattern, you always talk how many times it is happening in a second. Less than 0.5 hertz, 0.5 hertz, 1 hertz, and so on, right? So you go, even if you're describing continuous GPDs, which are 4 to 5 hertz. So you define that between 2 to 6 hertz of continuous generalized periodic discharges with maximum voltage at XYZ point. The duration of a given pattern, like a single occurrence. How much of what is the duration of the pattern that you're looking? Is it very long? So that means you're seeing that pattern for over an hour now. That again goes into your continuous discharges. Are they long? So sometimes the pattern comes, pattern goes away, right? So long pattern is that 10 minutes to 59 minutes. If it goes above 59 minutes, if it is 1 hour, it is a very long pattern. Then you have intermediate pattern, intermediate duration of a given pattern. Brief pattern, 10 to 59 seconds. You have this very brief spike and wave discharge, very brief sporadic discharge. So that's less than 10 seconds, maybe it happened twice in those 10 seconds. So the duration of a given discharge is described with these things, based on this time scale. Now the prevalence. What percentage of the record is occupied by the pattern you are describing? Is it happening continuous? Like the 4 slides I showed you at the beginning about the continuity, it sort of goes hand in hand with the prevalence, right? So pattern is continuous if it's happening more than 90% of the record. If it is abundant, if it is 50 to 89% of the record, then you have frequent, occasional, and rare prevalence of a given pattern. The plus modifiers. There are a total of 5 plus modifiers. 2 are only for PDs, 2 are only for rhythmic delta activity, and 1, there is only 1 pattern that goes both with PDs and RDA. So total of 5 plus modifiers, 2 for PDs, 2 for RDA, 1 that goes for both. So the one that goes for both is plus F. That means you have faster activity with your GPDs, LPDs, as well as you have that faster activity with rhythmic delta activity. Then you have the 2 patterns that goes for periodic discharges is plus R. That means your rhythmic delta. Now your GPDs can appear with rhythmic delta. Then you are going to call it GPDs plus R or LPDs plus R. The other thing is fast and rhythmic. It's fast activity and rhythmic activity. That is only for PDs. So it's kind of a redundant information. What are you using for periodic discharges? What you're using for rhythmic delta activity. Now, for rhythmic delta activity, we are defining it if it is happening with sharp activity. Sharps or spikes. RDA plus S. And then if the rhythmic delta activity is happening with faster frequencies as well as both with sharp activity. So I'm not going to show you pictures of this, but I do have a question here, a couple of questions actually. So based on the modifiers that we just talked about, 5 modifiers, how would you describe this pattern here? Is this rhythmic delta? Jeff, would you like to take over?
You may go through the question and I'll just publish the poll so that they can start answering.
Okay, so do you think this pattern is rhythmic delta with sharps? Rhythmic delta with fast activity and sharps, and if these are just LPDs with fast activity or LPDs with fast activity as well as rhythmic delta. What do you think this pattern, best describe this pattern?
And go ahead and enter that information into the poll. Give you 4 more seconds. And I will end the question now.
All right, so we have quite a split here. So when you look at this pattern, what pops up? Is it the rhythmic activity or if it is those periodic discharges? Now let's see how AZNS describes this pattern. So if you have said that this is lateralized periodic discharges with superimposed fast activity, you are correct. Now, why some of you chose rhythmic delta activity? Because if you look at the left side, you do see rhythmic delta with some faster frequencies. Now, what is it that is popping up in this record? If you are describing this EEG, there are two different patterns going on. We have lateralized discharges here. So what is the most malignant pattern that you're going to describe this EEG with? So these are lateralized periodic discharges on the right side, and they're happening with faster frequencies. Up here on the central, there is an artifact. See, that's why I didn't want to take the EEGs from the samples that I have collected, because then maybe I'm biased, right? So this is the best thing to say what pattern stands out when you look at it. I'm not going to say that there is no GRDA or LRDA happening here, but the pattern that is most malignant here is lateralized periodic discharges with superimposed fast activity. So it's going to fall into LPDs plus F category. All right, next slide. I have a couple of questions, Jeff, here. So go ahead, please, if you can take over for the poll. Now,
Okay.
This question here is if you can describe the pattern with modifier. Now, there are some stars, which kind of is a cheat sheet here, right? So would you describe this as lateralized rhythmic delta with sharps or with fast activity as well as sharps? Or you would think these are periodic discharges with fast activity or periodic discharges with fast activity as well as rhythmic delta. How would you describe this pattern?
And go ahead and enter in your choice in the poll. Give you 3 more seconds. All right, locking it in.
All right. So according to ACNS, the correct answer for this is actually, to everybody's surprise, A. So this is lateralized rhythmic activity with sharps. But if I am describing this pattern, and I think everybody is with me on that, so I don't feel guilty or wrong about it. This is lateralized rhythmic delta activity with overriding faster rhythms and sharps in it. So if you had said A, you are following the ACNS description of the pattern. But LRDA plus FS, I feel, is more honest description of this pattern here. So when you're describing it as lateralized rhythmic delta activity, please quantify it as 1.5 to 2 hertz of LRDA plus S. I feel good about myself right now. 80% of the audience is with me on that. All right, question number 5 here. Again, we have a pattern which we are going to describe with a modifier. So you see here rhythmic delta activity with sharp, or you are seeing rhythmic delta activity with fast frequencies as well as sharp, or you are seeing LPDs either with faster frequencies or with rhythmic delta. What do you think is the best description of this pattern?
And I'll bring this up in just a moment. So go ahead and choose wisely.
A lot at stake here.
4 more seconds. Okay. We'll lock that in.
All right, so 70% of the people who said LPDs plus R is correct. Before we look at the explanation for correct answer, let's talk why it is not RDA plus S. So the rhythmic delta activity is sort of masked by these discharges. So you have the major pattern that kind of stands out are the discharges, periodic discharges. So we are not going to categorize this as RDA plus S. LPDs plus F. Now, if you see the frequencies which are next to your periodic discharges, they are not faster rhythms. We are still in delta theta range. We are not going into those brief moments of faster frequencies. We are still staying in delta theta range. Now, the way ACNS describes it, it's LPDs with superimposed rhythmic delta activity. So here it is described as, if you look at these periodic discharges, and then this orange sine wave here is describing it as delta waves after your periodic discharge. So there has to be 6 or more in a cycle to categorize it a rhythmic delta. And here we have about 7 of them. So if a pattern appears with rhythmic delta 6 or more times, it's safe to say that you have LPDs with rhythmic delta. But if it is less than 6, we are not going to categorize as LPDs plus rhythmic delta. All right, the fluctuating pattern. So we do get confused to describe when our LPDs and GPDs are all over the place. They are jumping from one location to another. They're changing their morphology. They're changing their frequencies as well as voltage. So we are describing them as a fluctuating pattern, either in frequency or in location, or even in morphology. Now, there is a criteria. There should be at least 3 changes, not more than 1 minute apart. So in less than 1 minute, you should be seeing 3 changes happening in that pattern. So the first cartoon here is about the fluctuating in location of these periodic discharges. If you see, they are sort of fluctuating from F3 to F3C3, and then they are going back. So they are going back and forth from the frontal to frontocentral. And of course, the central location also is or is not involved during this less than 1 minute apart. Now, another one is frequency. Here is a pattern change in frequency from 0.5 to 1 hertz. That's when we give a range to describe our discharges. So either they are 0.5 to 1.25 or 0.5 to 1 hertz. And the other way to describe this fluctuation in frequency is best to count how many are you seeing in 10 seconds. Or if you are describing it in an epoch, make sure you describe 10-second epoch or 15-second epoch. The best, since it's a universal thing, we are using 10 seconds as an epoch, and we think 2.5 or more is considered as an event if it lasts for 10 or more seconds. So you count your fluctuating frequencies of the pattern if they are happening 12 times, 20 times, 25 times. So that's the best way. If you cannot count like what is the frequency, just count how many are happening in 10 seconds. So we'll come to that description in a second. All right, the next category is electrographic and electroclinical seizures. We have seen so many of those. So I don't have the slides to show these. But just as the definition goes, you know that an electrographic seizure is when you see the discharges more than 2.5 hertz for 10 seconds. So here, that's what I was telling. If they are fluctuating kind, maybe they're happening once in 1 second and 4 times in another second, you count them in 10 seconds. So if you have more than 25 discharges in 10 seconds, it's an electrographic event. Of course, you will see an evolution of those discharges. Now, electroclinical seizure or electroclinical event is always time blocked with your EEG pattern. When anti-epileptic drugs are given, it improves. Electrographic status epilepticus is something that lasts for more than 10 seconds. Now, this is another way of putting it on. If 20% of your 60-minute recording, that means a patient spends 12 minutes in an event. If the patient is seizing for 12 minutes in 1 hour, it's going to be counted as electrographic status epilepticus. That kind of creates a very thin line when the MD says, hey, don't contact me if the event is X amount of time or happening every 2 hours and things like that. But when you start putting those together, it is like more than 12 minutes in an hour. So you justify contacting the MD that, hey, this is the event that is more than 12 minutes in an hour, even if there were small events the patient had. The patient had 12 events lasting for 11 seconds in 1 hour. So that's going to count towards as electrographic status epilepticus. Electroclinical status epilepticus is something that is lasting for 10 minutes. Again, 12% of a 60 minutes, 12 minutes of a 60 minutes record is of those clinical events. And there is more than 5 minutes of bilateral convulsive activity. So out of 10 minutes, if the patient is convulsing for 5 minutes or more, that is going to be categorized as electroclinical status epilepticus. Now, what if it is not purely electroclinical? What if it is possible electroclinical status epilepticus, right? So there you're going to see everything you are seeing in the electrographic status epilepticus, electroclinical status epilepticus, all this up here in this rectangle here. But the clinical activity gets improved with anti-epileptic drugs. That means whatever patterns, the EEG improves, but there is no improvement in patients' convulsions. Now, at that time point, you have to start thinking that the clinical thing that is happening is subcortical. So patient's EEG has improved, but the patient is still in myoclonus. So that is a possible electroclinical status epilepticus. And again, there are no slides to show you of different kind of events and things like that. Now, another term that we are using more and more for our ICU adult population is BERDS. We were using this term only for neonates 5 years ago. The BERDS, again, there are two categories. You have possible BERDS, you have definite BERDS. So BERDS are nothing but, the way I remember it, those are seizure fragments. And they are happening where I was seeing epileptiform discharges. So these are either focal or generalized, and it is a rhythmic activity. Now, there have to be at least 6 regular waves. 6 regular waves of a rhythmic or focal activity lasting less than 10 seconds, but more than half a second. And they are definite if you see clear evolution, but they do not go above 10 seconds. As soon as they go above 10 seconds, we all know, right? You also know that it is an event. And they have similar morphology of the epileptiform discharges and the events patient was having. Possible is they do not look like epileptiform discharges. They are just sharply contoured. They are not evolving. So your question, are these possible? Are these definite? If you're not sure, I think it's safe to use the term BERDS. Then you go up and follow this category up here. They are focal or generalized. There are 6 regular waves, which are of more than 4 hertz of duration. And they last for more than half a second, but less than 10 seconds. All right, we have another question here. You have 2 different patterns in this image. One is underlined and one is closed in a box here. So how would you describe the underlined pattern? Are these definite BERDS? Are these LRDA? Is this a seizure or it's a possible BERD? So please remember, I'm using the term seizure since I'm copying the ACNS terminology here. As a tech, we are not using the term seizure when we are describing these patterns. We are always using the term event. So Jeff is going to open the poll. So based on what you are seeing, the pattern which is underlined, what is that pattern? How would you describe it the best?
Give you 5 more seconds. All right, I'm going to lock it in.
All right, so 60% got it right. These are definite words. Before we come to the explanation, let's say why it is not lateralized rhythmic delta activity. It is because if you see, it is rhythmic theta activity. It is 5 to 6 hertz. So LRDA is out of question. And then they are not possible birds. If you look at the rectangle here, these epileptiform discharges which are closed here, if you see our birds, definite birds, appear at the same location and are of same morphology as that where epileptiform discharges are appearing. So I'm going to go to the previous slide to confirm why these are definite birds. So there is a similar morphology to those location of the IEDs and where the events will happen. Anyway, we are not seeing any events in this one. There are 6 regular waves of more than 4 hertz. We saw 5 to 6 hertz, and they are lasting less than 10 seconds. So they are falling under the category of definite bursts. So let's see what the ACNS is describing it as. So these are brief, potentially rhythmic discharges similar to sporadic epileptiform discharges. So in this rectangle here, these are our sporadic epileptiform discharges. So it's definitely bursts. These are not potential bursts, these are definite bursts. So always count the frequency before you come to a conclusion. If it is rhythmic delta activity, count what is the frequency of those discharges. All right. Ictal interictal continuum, it is one of the most confusing pattern. Patient is seizing, patient is not seizing. There is no clear onset, there is no clear ending. The discharges are not 25 in 10 seconds. And the lateralized rhythmic delta activity is not just LRDA. It is happening with modifiers. So there is so much of going on during the interictal continuum. So if you cannot decide, so what are we going to do? It is, first of all, keep in mind, interictal continuum is that brain is ready to take off. It can seize at any time, but it's not seizing. So it is right at the point where it can seize at any time. Any minor change in the neuronal activity, in the toxicity in the brain, all those metabolites that are accumulating, it's a ticking time bomb, basically. Now, again, interictal continuum is purely an electrographic term. We are not describing patient's clinical state with that, right? However, when you see this pattern, patient has impaired awareness. How many times we have hooked up a patient with altered mental status who's not seizing, but is having these epileptiform discharges, which are semi-rhythmic, maybe rhythmic, they are sporadic. It is mix of everything, basically, right? So impaired awareness, it can cause some clinical signs. It is not status epilepticus. It is not an electrographic event. So what exactly it is? So if you count those discharges, they are always more than 10 and less than 25 in 10 seconds. So, and they appear with a plus modifier. So there is a fluctuation happening, fluctuation in the frequency, fluctuation sometimes in the pattern, in the morphology of those discharges. So your takeaway points for interictal continuum is you are seeing a pattern continuously or discontinuously, but those discharges are more than 10, less than 25 in 10 seconds. That's why the importance of counting them in 10 seconds if you're so unsure whether to mark it as an event or not an event. So you count them in 10 seconds. And if they are appearing with a plus modifier, and if they are fluctuating, but they are still less than 10 per second, they are still less than 10 per second, then they are going to go into IIC. Now, what about lateralized rhythmic delta or multifocal rhythmic delta? Again, so more than 1 hertz of delta for more than 10 seconds. That means you're going to see 10 waves in 10 seconds with a plus modifier. So your LRDA plus F, LRDA plus S. So if you're seeing that and it is happening in continuous pattern, then you call it an IIC. Any doubts? Always reach out to the MD. So we are trying to get a webinar purely on ictal interictal continuum to clear up all the doubts that we are having. All right. So there are a couple of pictures here. Based on this one, do you think if it is interictal continuum? So it's an EEG from the same patient, 3 images, 3 pictures of EEGs. So what do you think? I mean, we all know that these are generalized periodic discharges based on the frequency, based on their morphology. Do you think it's an interictal continuum? Go ahead, please.
Go ahead and put in your choice.
So while you're answering, if I say this pattern is continuous throughout the 24 hours of recording, this is the pattern. So then would you consider it as IIC?
Giving you 5 more seconds. Locking it in.
All right. If this is a pattern you are seeing throughout the recording, throughout your 4 hours of shift, this is an interictal continuum pattern. And if it is happening for 10 to 15 seconds, it is not. So you are having sporadic discharges, intermittent discharges happening for X amount of time, and this is the frequency. So this is not IIC if it is happening just for a few seconds. But again, if it is happening throughout, then it is going to go into a category of IC. Right now, just this 10-second image, according to the ACNS guidelines, it says that these are generalized periodic discharges. There is no modifier here. There is absolutely no modifier. So that's how it gets a little bit sort of overwhelming. Like, how am I categorizing it? So you are monitoring for 4 hours continuously. Now you see how this pattern is changing over a period of time. You are seeing continuous 1 Hertz GPDs. Now these GPDs start to appear with a modifier. When it is appearing with a modifier, you are putting it in a category of IIC. If it is not with a modifier, you are going to continue to mark it as 1 Hertz GPDs. So ACNS terminology, it is not an IIC. But let's see how this pattern changes from the previous page. Now, what are we seeing here? Do you think these are fluctuating TPDs? This is IIC. Is there anything new that you are seeing here which tells you that, okay, this is interictal continuum? So what do you think here? What's happening? So from previous slide, where we were seeing 1 Hertz TPDs to this one here. Jeff, can you take over the poll, please?
Absolutely. Here's the poll. Give you 5 more seconds. And locking it in.
So we have a perfect split. This is what I was telling. The interictal continuum is a very confusing pattern. So we have 30, 40, 30. So 40% think it is interictal continuum, and 30% each thinks that these are fluctuating GPDs. So when your GPDs are fluctuating to this extent, and if you see there is a modifier appearing with this. I'm going to go to the previous slide. So here we have generalized periodic discharges. Now, if you look carefully here, we have some faster rhythms appearing in between these discharges. So this is both fluctuating GPDs. If you write it fluctuating GPDs, that's correct. If you think it's interictal continuum, yes. Now, if it is a downhill from this pattern, so the patient is getting into an interictal state and may cease at any time, because change in frequency of GPDs along with modifiers is going to be more and more malignant. So this is what the ACNS says. So you have 1 hertz, 1.5 hertz, and the hertz are fluctuating between 1 to 1.5, and there are faster frequencies appearing here. So this is qualifying as an ictal interictal continuum pattern. So fluctuating GPDs continuously happening, changing in frequencies, is going to be an interictal. So here we have continuous GPDs. If you count them in 10 seconds, you have more than 25. So the pattern is getting worse from, so I'm going to go to the slide number 1 here, where we had just the GPDs getting into interictal continuum. And here we have continuous discharges, 2.5 hertz, with rhythmic activity, with fluctuating GPDs plus R. So we have rhythmic activity happening. And I think they're a little shy of saying that there are faster rhythms here too. But again, it is a subjective thing. So these are GPDs plus R and 1.5. So before we had 1 to 1.5 hertz of frequency. Now the frequency has increased to 1.5 to 2 hertz to 1.5. So we have fluctuating frequency and rhythmic activity. So these two are a recipe for interictal continuum. And if you see these 3 patterns, if you see patterns changing from here to here to here, it's a significant pattern change, calls for contacting the MD. All right, if there are any questions, I'll take it. You did get all the resources that I used to put this PowerPoint together, and you will be receiving that. It's all from the ACNS website. Any questions?
So if you have any questions, go ahead and enter them into the chat, and then we'll address those as a group. And we'll give you just another few seconds here to enter anything in. So the first question we have now is FRDA still an allowable term?
Frontal rhythmic delta activity. So the best way to describe, according to the new terminology, is frontally predominant GRDA. So we are not using the term FRDA, because FRDA is nothing but what we were using before, FRDA and TERDA. So we are not using FRDA, so GRDA of frontal predominance. That's the correct thing.
All right. Just for clarification, this webinar was not submitted to ASET for CEUs. We will look to see if there's any way to do that post-webinar, but again, it is something that we'll investigate and let you know.
So as per the ASET guidelines, the employees can claim 10 of those CEUs from their employer. So this will be one of that.
Excellent.
They can claim 1 CEU if they have attended it live, but not the recorded one.
Okay, very good. So the recording will be posted in the next 2 days. You'll get an email with the link to pull this back up at any point in time, and we'll put it on our YouTube channel as well. All right. Thank you, Navita. It was excellent. We appreciate it. And we will have you back in September. Take care.
See you all then. Thank you so much. Thanks, Jeff.
Bye.
Thank you for coming.